The next presentation are the doctors Louisa Marion-Bellemare and Dr. Julie Samson.
Push this. Okay. So thank you so much, everyone, for having us today. We really appreciate this. This is a real passion for Julie and I. It's been my passion for quite a few years, and then I begged Julie to jump on board, and since then it's been nonstop action. It's been great. Okay, so today we're here to talk about the opioid use disorder crisis in our community. And of course, we have to set some goals for the presentation today. And I apologize, they've told us we had a very strict guideline timeline, so we're going to try and not go over that. But feel free to answer some questions afterwards. So the goal of our presentation today is to review the evidence. And we are supported medically by both provincial and national guidelines on how we are supposed to be treating people with addictions. We're also going to talk about recommendations for improved substance use disorder and treatment in Timmins and, of course, the surrounding area. We really have to look at what we currently have here in our community and how those services are performing, and then discuss our vision and consideration for implementation. And we need to improve our addiction system. And we all know that at this point. It's not something new that we're talking about today. We need to figure out how we're going to do it. So first I'm going to start with a definition, because this is very important for everybody to understand. And we talk about addictions for years, but now with the fentanyl era, we really need to understand addictions. So the definition of substance use disorder is actually a chronic relapsing illness. And though associated with elevated rates of mortality and morbidity, it has the potential to be associated with remission. So with appropriate treatment, people can live the lives that they want to if we can provide them with the appropriate treatment. It's also compulsive disorder. And for those of us who have never suffered from addiction, it's very hard for us to understand this. But if you can understand it's a medical condition with both chronic relapsing illness and compulsive disorder, it has a strong desire. People want to stop and they want to cut back, but they have an inability to do so because physiologically their brain has changed when they've been using these opiates for a long period of time. We also have new criteria set out by the DSM-5, and this is a manual developed by psychiatrists, and it has specific criteria for opiate use disorder. And you need to only fill 2 out of the 11 criteria, and we can go through and people can be diagnosed as mild, moderate, or severe.
All right, so I'm just going to go over a few stats here just to keep things in perspective about what's going on nationally, provincially, and more so in our city of Timmins. So nationally in Canada, there's been an increase in death rates related to opiate overdoses. We all know that. It's been going on since 2016, since the introduction of fentanyl in the drug market. In 2018, from 2016 in Canada, there's a 48%, almost 50% increase in death rates from opioid use disorder and overdoses. This affects as well, not just death, but our hospital admissions nationally. Hospital admissions for related opioid use disorders and complications of that have increased up to almost 30%. These admissions are infections from IV drug use, infections, abscesses, and more serious infections, which we call infective endocarditis. Infective endocarditis is a heart infection. Patients are in the hospital up to sometimes 6 to 8 weeks getting IV antibiotic treatments, and some of them need valve replacement. This is all due to IV drug use. In Ontario, opioid use disorder deaths have doubled since 2015. Biggest increase again was with the introduction of fentanyl in the drug market in 2016. Our area has been doing poorly and terribly. Overdose-related deaths in 2019 in Timmins was a total of 20, making our death rate per 100,000 population in 2019 high at 46. This year, I have the stats from January to May. We've had so far confirmed and probable deaths from opiate-related overdoses at 17. And since then, just from working in the emergency department, we know that number will be much higher. We are doing poorly. Our death rate is high, higher than the provincial average at 11.2, higher than Vancouver, which is well known, unfortunately, for its addiction issues. So our death rate our amount of deaths in 2017 was at 2 in Timmins. 2018 increased to 10. 2019, 20. This year will be much higher. We are doing the worst in terms of death rates in Ontario, and I could even argue possibly nationally. And this is just in Timmins, not even Timmins and area. We also know we have a lot of issues with homelessness in Timmins. I am not saying by far that every homeless person has addiction. Addiction affects all social economic status. But if you have homelessness, you are at risk of more addictions. So you can't solve one without solving the other. They are hand in hand. If you give people addiction treatment, they are more so to get income, stable housing, employment, and homelessness goes down. So where do people with addiction, with opiate use disorder, go to get help in Timmins? Well, ideally, community safe beds should be available where they get them out of crisis mode, get them help at that time, social services, addiction treatment, withdrawal treatment in safe beds. Well, also community withdrawal management services should be available. These are things that we know as detox centers. These should be available for our patients in the community. In reality, we're having issues with that here. So where do patients go? To the hospital, our emerge department. And then they're admitted to the mental health unit because we have nowhere to send these patients from our department. It's challenging discharge planning. They're discharged sometimes to living space without follow-up, but often they're in our hospital taking up beds and space that we should be treating patients with concurrent mental health illness and not addictions. Addiction crisis in Timmins, safe beds. We've had issues with safe beds in this year. Access to safe beds from TPS this year was at 0. Safe bed occupancy from April to June, 0, in keeping with COVID. We are the only town in Northern Ontario where the safe beds were closed. So again, these patients are showing up at our emerge department. Withdrawal management services in Timmins. People know this as a detox center. No available detox center in Timmins where we need it the most. Our closest detox center is in Smooth Rock Falls, more than an hour away, which is a challenge and a barrier to get patients there. As I said, these patients are admitted to our hospital. We have a very high rate of admissions due to addictions at our mental health unit. The average in the province is 28%. We're sitting at 65%. We are, in essence, working as a detox center in a mental health unit as opposed to be taking care of patients with mental health illnesses such as schizophrenia, depression, anxiety. We are working as a detox center. Addiction issues are changing, and that's what we need to realize. It's no longer Percocets and Oxys from the 2010s. We're talking about fentanyl, heroin, carfentanil, tons of IV drug use. Times are changing, addictions are changing. We need to change how we treat addictions as well. Just to show you the death rate, this is from Public Health Ontario from 2003 to 2019. In the last 2 to 3 years have been due to fentanyl. It's a big issue. We have it here. We see it here. We need to treat it well.
So next I'm going to discuss a summary of national practice guidelines that we should be following, and most communities are following these provincial and national guidelines. And in Timmins, we're not there yet, but our hope is that we get there, and we're going to work on this. So just to give you some definitions, OAT means opiate agonist therapy, and we're referring to Suboxone or buprenorphine and naloxone, and methadone. Suboxone should be offered first line when we consider treatment options for people who are in acute withdrawal or people who present wanting to abstain from opiates. And methadone should be offered as second line treatment option. We have extensive clinical practice guidelines. These are 11 guidelines. I'm not going to go through them all. And it's of utmost importance that we treat these people according to these guidelines. When we have people come into our practice with other illnesses, such as a new cancer diagnosis or diabetes, we treat them according to clinical practice guidelines. Of course, there's always outliers. There's some people that don't fall perfectly into these practice guidelines, and we have to make other clinical decisions. But we know that the majority of people, when it comes to treatment for most medical conditions, most of us fall within the same area for treatment. So one thing we do know for sure is that people who are on OAT, so methadone or Suboxone, it saves their lives. There's a decrease in overdose-related mortality. It actually decreases mortality by 70 to 80%. We give aspirin to people to help reduce their chance of stroke, and it only reduces their chance of stroke by 65, 60%. We're talking about drugs that can reduce your risk of death by 70 to 80%. And we still have a lot of reluctancy to be providing patients with these in our community. It decreases morbidity such as HIV, Hep C, as Julie talked about earlier, and infective endocarditis, which is an infection in your heart, etc. The other really fascinating fact is people who do participate in an evidence-based program, the yearly retention rate is 74%. These are huge numbers. We don't see these retention rates in many areas of medicine. Patients in these treatment programs are likely to remain in remission, become employed, and have stable housing and come out of homelessness. These are treatment algorithms as physicians that we often use. It's set out for us. It's pretty basic. We need to follow the evidence-based guidelines that have been provided to allow us to save people's lives. But a lot of it is based on stigma. We're still treating addictions like we did 30 years ago with the inception of some of our area addiction treatment centers. We need to understand that since 2015, this has changed and the treatments of addictions has changed, and we have to change with it also. Opiate agonist therapy, so methadone and Suboxone, must be a standard of care. It shouldn't be an option. We should be providing people with this at any point along their journey of their addiction treatment. We're also bound by benchmarks. So in medicine, this is something people don't understand, but we have certain benchmarks, and we try to treat people according to the evidence. We had Health Quality Ontario benchmarks set towards opiate use disorder in 2018. So this is 2 years ago, and we haven't really met a single one of those benchmarks in our own community. Thanks. The first benchmark, which is very important, is that people who are in moderate to severe withdrawal, they should be offered relief of symptoms by either Suboxone or methadone within 2 hours. Suboxone should be our first line because it carries a much better safety profile. It is the most effective treatment for withdrawal symptoms. Our other benchmark is that for those people who are actively using and are asking for our help, they should be able to receive treatment with OAT within a maximum of 3 days, not 6 weeks, not 3 months. These are Ontario benchmarks that we need to start meeting. Again, Suboxone must be the first line of treatment, or should be. The other key component is this, and we see this all the time in the Emerge, is patients who are going to Monteith or being admitted to the hospital or other treatment programs, they're not being started on OAT, or their OAT is not being continued, and they end up in withdrawals and become very ill. We should be treating these people with OAT, either continuing it or starting it prior to being admitted. Oh, thank you. The other very important component about meeting these Health Quality Ontario benchmarks is that people need to be receiving concurrent psychosocial treatment, support, and monitoring for a minimum of 6 months. We don't even have anywhere in our community or surrounding area that can offer that at this point. And these are benchmarks we have to meet. These are for patients who have been stabilized, who are looking for jobs. We need to be following them on a regular basis to ensure that they're getting the assistance they need. If we can remember that this is a chronic illness that needs to be treated, we can understand why people, it's like somebody who's had a heart attack. They continue to follow their cardiologist for years. People who decline treatment and don't want Suboxone, they should be offered opioid tapering. And this needs to be over a very long period of time so they don't go into withdrawal. The other important benchmark is people need to have access to safe consumption sites. This is to improve and decrease the risk of mortality related to and morbidity related to infections. And Julie will touch base on this a little later. One other important thing is withdrawal management alone should be avoided. This is people who go into acute withdrawal without any medical treatment or assistance. It increases the rates of relapse, it reduces their tolerance to the drug they're using, and it leads to morbidity and death. We see this often in our emergency department. People come into active withdrawal, they want to quit their drugs. They're not offered appropriate treatment. There's nowhere for them to go. And 3 days later, they go out, they use, and 3 days later they come back and they're deceased in our emerge. It's because they lose tolerance to the drug they're using because they're required to quit cold turkey. We also have to set out a care plan for these individuals like we would do for any other medical illness. We need to have same-day access to harm reduction services. We have to have access to ongoing treatment like we discussed within 3 days. We need to talk about naloxone kits, overdose education. We need to talk about housing and occupational needs and income support. We need to connect them, if we can, with a primary care provider. And we need to provide psychological ongoing treatment, including trauma-based and culturally competent care, and of course, ongoing pharmacological treatments for concurrent mental health disorders. We also, we know that people who have addictions also have a significant increase in post-traumatic stress disorder. And it's very important to identify these individuals. Unfortunately, in Timmins, we're not even coming close to meeting many of these benchmarks. So we were fortunate, and I don't think a lot of people know this in our community, but we had what's called Timmins and area needs-based planning research. This was actually unbiased research by the direction of the Auditor General to assess the needs of addiction services in our area. This was done in 2019 and early into 2020. So we've had research already telling us what we need to do in our community. The unfortunate thing is it tells us what we need, but not how to actually go through and do it. That's our job to figure out how to follow through, but it did tell us what we need. It was also supported by the Center of Excellence, which assigned core services to our community. And this research gives us an opportunity to back up the change that we need to make to go forward. We have evidence that was supported, research that was driven in our own community. So we can use this and support it going forward. We're not making this up. It's going to validate our need for change and review our needs. And again, it doesn't address practicing good medicine. We continue, although we can receive funding and be told what services we need, it's still very important for us to understand that we still need to be practicing good medicine and evidence-based medicine with respect to the treatment of these individuals. And it does support the need that we need to diversify our services in our community. This is just a little chart here to show you the needs-based planning research. So when we break it down, it looks at acute intoxication services. So this would be acute withdrawal management somewhere, for example, like Smooth Rock Falls. Then we go through and it talks about home mobile services, where people who want to actively withdraw in their home can have support in their home, and we don't have any of this at all in our community. We talk about residential services. It talks about the projected need and what we have. We actually have too many of those areas in our community for what we really need. We have no hospital complex beds, so when somebody comes in acute withdrawal and is admitted to the hospital, they just get admitted to our regular ward and are treated that way. And the other thing is, the last section is, we need day programming, evening programming for patients. When patients become stable and in remission from their opiate use disorder, we need somewhere where they can check in when they start going to work, if they're caring for their children. I talked about this 6-month plan as a benchmark that we need to have for every one of these patients. We need somewhere for them to go to access that care. And we don't have anywhere for them to go right now in Timmins for these patients who become stable. So what the needs-based planning did show is that we have a lack of acute withdrawal management, including home mobile and hospital complex. It shows that we have too many community residential beds for what we actually need. The evidence demonstrates that acute withdrawal management is a priority, not residential. We need to have access to services to treat the majority of people with opioid use disorder, not the minority. This does not mean that we don't need residential treatment. It means that we need less of that. Within the fentanyl era, we have realized that we need acute, immediate access for patients. When they ask us for help, we need to be there for them. The issue with residential treatment, it takes a very long time to get into. Priority needs to be given to programs and initiatives aimed at strengthening both the opiate agonist and residential treatment programs. Many of our treatment programs don't recognize people on opiate agonist therapy, and they aren't accepted into programming. So even if I do start them on a medication in the emerge or in the hospital, they're not accepted into programming on the medication that we know saves lives. And this is our struggle as physicians. It also shows that we have enough acute withdrawal beds. So we don't need more of these beds. But the problem is currently they're not practicing true evidence-based acute withdrawal management. People need to be stable on OAT, and we know the evidence shows that people need to be treated immediately with OAT. But in order to be accepted in acute withdrawal management bed, they must be stable on the OAT, which just doesn't really make sense. Our acute withdrawal management beds are not locally accessible. They're an hour away. The bus only goes there 3 times a week, and the bus is at 10 p.m. It needs to be true withdrawal management. If we're going to call ourselves an acute withdrawal management facility, we need to be doing acute withdrawal management according to the evidence for opiate use disorders in 2020. It must be medically supervised, and we cannot have beds limited, meaning if you're on OAT, not on OAT, if you have issues with alcohol addiction, people need to be accepted on a first-come, first-served basis. And we can't be having very strict admission criteria. We've also thought of this notion about having a umbrella model of services in our community, meaning that we have an umbrella and all our community services fall under there, so that we all become accountable to each other, because that's very important for moving forward. When we look at home services, right now in our hospital, and we can attest to this, that I'm going to tell you, we weren't doing a great job in our own hospital treating people with addictions. We've decided as a group to move forward and start treating people appropriately with respect to the evidence. We've implemented in our hospital an addictions medicine consult team. And we're following the clinic practice guidelines to improve the treatment of people both admitted in our ED department. We've also started an in-home withdrawal management, because if you remember on our needs-based planning, we had 0 of that in our community. This allows people to be able to withdraw in the comfort of their home and continue to go to work if they need to and care for their children. We also have mobile crisis and TPS working together. We don't have any designated complex withdrawal management beds in the hospital at this time, but that's something we're going to hopefully look at in the future. We need to ensure that we have successful implementation, and we need to be accountable for these services we're offering and ensure that we are practicing according to the evidence. What we'd like to see happen in our community is we need to consider repurposing our current services. We need to look at everything we're doing, review all the evidence, look at our patients, look at our overdose death rates, and realize we really need to change something. And we can go through, again, the evidence over and over, but what we really need to realize is that the patient needs to be at the forefront here. If we cannot treat the patient appropriately, their success and their chance of returning to the life that they wish is very, very low. We need to also realize that OAT is safer and more than effective than treatment that does not include OAT. We also want to look at strengthening our programs in our community between the RAM clinic, which is considered the rapid addiction medicine clinic, and addiction medicine consult team. So we want to have a better connection between what we're doing in the hospital and what we're doing in the community. This is to ensure that we have really good discharge planning, so when a patient comes into our hospital with an addiction and is suffering from an infection and is admitted, that we ensure they have good discharge planning and follow-up in our community. We need to consider what other communities are doing in order to strengthen our relationships. I don't think we should be making this up. I think we should at least be on par, if not better, to other communities. Again, we need to look at funneling our services through an umbrella model. And we need to remember another important factor is that treatment for people who suffer from addiction should never be punitive programming. You should never be kicked out because you use. You should never be kicked out because your urine drug screen is positive. We need to reflect on our treatment, and we need to ask patients why and what it is that we can do to continue to help them. Every time we engage with a patient with an addiction, it plants a seed for them to get help the next time. And that's our goal as a community, is to hopefully someday a patient that you meet on the street will come in and receive treatment. So safe beds. So when we divide up how withdrawal management works, we have our acute withdrawal management, what I was discussing with you that we have currently in Smooth Rock Falls. We also have safe beds. Safe beds need to be easily accessible by the police, mobile crisis, and medical staff. These are for people in true crisis. People who are found on the street, don't know what to do, don't know what they want, and they can access these beds. These beds must be available 24 hours a day, 7 days a week, 365 days a year. And they have to have medical supervision. Often these people have concurrent disorders and they're going through withdrawals. Again, because I'm pushing this umbrella model, it needs to be under the same umbrella so that we can have people accessing these services at any point. And they'll be connected with appropriate treatment for substance use disorder. And we have to remember we cannot have strict admission criteria for these patients. They need to be accepted into treatment. Oh, it's still me. Sorry, guys. So with respect to community residential treatment, we need to understand, and we talked about this, and this is part of the Health Quality Ontario benchmarks, is that withdrawal management alone is unsafe. If we ask somebody to stop their opiates cold turkey without treatment of OAT, their risk of relapse and death is 60 to 90%. These numbers are huge. Not only is it somewhat inhumane to ask somebody to be and go through withdrawals, of course, unless that is the type of treatment they decide. Withdrawal management without subsequent treatment is strongly advised against. It should only be offered if nothing else works or people are refractory to treatment. Unfortunately, the majority of the services in our community are residential treatment services. And residential treatment services often don't accept people with opiate agonist therapy. We need to shift our current services to less residential and have more short-term acute withdrawal to stabilize patients who are acutely unwell from opiates to then move them on to residential treatment. There's limited evidence of efficacy of residential treatment to other treatments with opiate use disorder. I think that's pretty much what I said. So when we also look at intensive complexity enhanced services, these are the day programming services that we talked about. So once a patient accepts treatment, either they go to a safe bed to be stabilized, or they go into acute withdrawal management to be stabilized. Then the next thing is, once they're stable, is we need to have a plan. Yes, some of these people will end up in residential treatment. Some of these people will end up going home. Some people will go back to work. But what we need to provide them to meet the benchmark is a minimum of 6 months of follow-up care where we're providing them with adequate treatment. And this is going to be through day and evening programming.
I'm going to speak to you now about harm reduction. I think this is a very important topic that we need to discuss. Harm reduction, we're working on this from a hospital setting, educating our staff. That includes, nurses, social work, and physicians about opiate agonist therapy, safe injection practices, and orders. So all the physicians are getting more comfortable with starting patients on this. We are trying to educate our own physicians on how to do this, and we actually have a presentation at 8 tonight to do that. Community-wise, also education needs to be done there and continued about safe injection practices, clean needle distribution exchange program that the public health unit has, increase in outreach workers to continue the involvement in the shelters, and looking into an overdose prevention site. So an overdose prevention site. We all have our opinions. We all have our biases. I was there until I looked at the stats. You're all entitled to your opinion, but the facts are the facts, and that's what I'm going to present to you at this point in time. Overdose prevention sites, also called safe injection sites, safe consumption sites. These are legally sanctioned, supervised facilities designed to reduce the health and public order problems associated with illegal injection of drugs. They allow the consumption of pre-obtained drugs in an anxiety and stress-free atmosphere under hygienic and low-risk conditions. These are the sanctioned sites where you get your federal exemption and then your funding from the Ontario government to get these going. Unfortunately, that takes a long time. There's also unsanctioned sites in different cities. These are ran by volunteer grassroots organizations as pop-up sites for supervised injections of IV drug use. They're often started as unsanctioned sites and move on to sanctioned sites when they get all their application done. What are the goals of these? Well, it's to reduce public disorder, enhance public safety, less needles on the ground, less overdoses in your streets in Timmins, less drug use in your streets, reduce overdose morbidity and mortality, reduce transmission of bloodborne infections. And in these sites, you improve access to other health and social services. And it always promotes entry into addiction treatment programs. Overdose prevention sites has been shown to save lives. And I think that's what we want here. We want to save lives. Our death rates are huge here, and this could make a difference. It decreases overdose fatalities by 35%. It decreases HIV and Hep C rates. It decreases ambulance calls in these sites. There's less ambulance calls by 67% in these surrounding areas. Less hospitalization because of less infections, and therefore less ER visits as well. What's available at these sites? Well, there's nursing services where they can do early recognition of infections, therefore decreasing ER visits and hospitalizations, where they also educate patients, clients about safe injection techniques. There's psychosocial support there with social work, counseling services, and also access to referral services for these people, for acute withdrawal management, opiate agonist treatment, RAM clinics, and legal advice. So what does it do? Let's look at harm reduction here. The Insight Clinic in Vancouver has been operational since 2003. These are not new. They've been used in Europe since the 1970s. So I've done a lot of studies around this Insight Clinic in Vancouver because it's been there since 2003. In this study, 75% reported a change in their injection behavior. Therefore, more hygienic injections, less infections. What's more important, 23% had stopped injecting by the end of the study period. 57% had entered addiction treatment programs, and 30% had used withdrawal management services. These sites make a difference. They don't just promote and enable patients to continue IV drug use, they help them make change. Crime rates, you always hear, oh, it's going to increase crime rates. There's several studies looking at crime rates around injection sites. The Insight Clinic in Vancouver demonstrated a decrease in the overall crime rate, decrease in vehicle thefts and break-ins and drug trafficking around the injection site. In the States, another study confirmed this as well, that there was no increase in overall crime rate around the surrounding community with this overdose prevention site. This is a picture of the Insight overdose prevention site in Vancouver, operational since 2003. The next picture I'm going to show you is a picture that I took here in Timmins. I won't tell you where, but this is a picture I took in Timmins. This is an area where obviously patients, clients, I should say, are IV drug using. They have put up their own safe injection, safety container for their needles. But this is going on in our town. This is sad that this is going on and we're not helping them. We could set up a safe consumption site, an overdose prevention site, to allow them to get services and help, instead of enabling this type of injection going on in the bush without hygienic and without services there to help them through this. This is a consideration of reorganization of our services here for the patients. Right now, the community services are fragmented. They're difficult to navigate. There's barriers for access and treatment. We think it should be under one umbrella, which controls all the services and helps them speak to each other and helps navigate the system for the patient. Opiate use disorder is a medical condition that requires evidence-based treatment. Suboxone should be the first-line treatment for this. We must meet the benchmarks that Dr. Marion-Bellemare mentioned. We must use the clinical practice guidelines. Withdrawal management alone and abstinence-based treatment are dangerous. We have to get away from that. We have to improve how we treat these patients. The needs-based planning demonstrate that we do need the change. Now we have to get together with these services and health service providers to be able to do this. Harm reduction strategies need to continue and need to improve. We need to continue on psychosocial supports for these patients. We need to have the umbrella model of services and treat concurrent disorders. We need to improve the level of comfort with using these medications with our healthcare providers in our hospital and in the community. And connect patients to services more easily. No matter where someone enters the system, be it high school, police custody, living space, doctor's office, hospital, they need to have access to support with immediate treatment.
So this is mine and Dr. Samson's vision for Timmins. We developed this ourselves. We think the people of Northern Ontario with substance use disorder will and should have an integrated, comprehensive, and concurrent treatment of their addiction, physical health, mental health, social and cultural needs. Treatment is offered according to best practice and evidence-based care to improve treatment retention and outcomes and subsequently reduce morbidity and mortality. We're not done. We got a couple visions. We want community partners to come together united without judgment to embrace the changes necessary to improve the current state of addiction services and ensure we are following evidence-based practice and meeting needs and demands for people with addictions in our communities. We must ensure that the person/patient with an addiction is number one, and we put our biases aside, and we need to be comfortable with the unfamiliar. We need to reduce barriers for people with addictions by reallocating services and funds to best support patients with addictions. We need to develop a coordinated umbrella model addictions group that drives and supports the community partners and ensures a medically evidence-based approach to treatment, and we need to be held accountable for this. We need to reduce morbidity and mortality for people with addictions. We need to provide compassionate care with a trauma-based and culturally competent approach with harm reduction strategies. We need to avoid withdrawals. This day and age, if people want to quit their addiction, they should not need to go through withdrawals unless that's their choice. We need to treat the addiction and we need to get out of our comfort zone. We need to push towards community home mobile treatment approaches and not residential. It doesn't mean we don't need residential treatment, but we don't need as much as we have today with all of these new approaches in place. We need to improve withdrawal management services in our own hospital, including implementing complex withdrawal services, and we need to have a safe consumption site. So what now? Well, I think we all agree that the status quo cannot continue, and that our inactions are actually contributing to people's deaths. We have to act now to change how addiction services are delivered. We need to come together with the primary goal to decrease mortality. We need to decrease deaths in our community. We know, as Dr. Samson provided us, that harm reduction saves lives through the evidence. She provided excellent evidence regarding this. We need to work outside our comfort zone, and we have actually a moral authority to do better in our community. So if you ask Dr. Samson and I what we think the immediate short-term solutions are, because this is probably what you guys have all been waiting for through this long presentation, is we need acute withdrawal management in our community. It must be medically supervised because we know the treatment for opiate use disorder is evidence-based and requires medical supervision. And this has to be done, and this isn't currently being done. We have to meet the HQO benchmarks where we talked about within 2 hours of withdrawal, they need treatment. If someone's asking for treatment, it's a minimum of 3 days. It must be evidence-based and treated with opiate agonist therapy. It has to be local and accessible. It needs to be 24 hours a day, 7 days a week, 365 days a year. People who are asking for help don't have time. The risk is they go out and use and die if we don't offer them help when they're asking us. And it has to be under an umbrella model. We also need access to our safe beds. They also must be medically supervised. We need to be providing evidence-based treatment, and they have to be accessible by TPS, EMS, hospital, mobile crisis, and other community partners. They can't be closed. They need to be 24 hours a day, 7 days a week, 365 days a year. And again, they must be an umbrella model. And lastly, we need an overdose prevention site in our community. So those are the three top things that we think need to happen. That's it. I think we went over. Sorry.
Well, it was a stunning presentation, impactful. Questions and comments on that presentation? Councillor Roger?
Your Worship, is the Jubilee Center still open? Still open on Jubilee? Because I remember one time we used to bring people with alcohol or drugs. We used to bring them there and not make a phone call, and you would meet them at the door and bring them in. Is that still open or is that closed? I don't know.
So yes, the Jubilee is still open. Again, addiction treatment has changed. At the inception of these community services 30 plus years ago, we had alcohol, cocaine, a little bit of heroin addiction. It's changed now. So people need immediate treatment and they can't wait. So yes, it is still open, but it isn't necessarily following the guidelines for evidence-based treatment for acute withdrawal. But we have to remember that it's a bit confusing, the context of withdrawal management services, because the Jubilee Center is a residential treatment center. It's not acute withdrawal management center. We don't have acute withdrawal management in our community. So the Jubilee is acting as a residential treatment center, which it should be, because that's what it's defined as. The issue is it houses our safe beds. We're supposed to have accessibility to 6 safe beds at any given time. The issue is, as the statistics showed, and if you speak to many of the police officers in mobile crisis, the admission criteria to those beds, it almost is impossible to drop somebody off. And they actually haven't been open for various reasons. So these patients have not had access to those beds, which are funded for our community. So that's why we're proposing a model where we have one addictions group that works together with all the community partners, that we become one addictions group so that everything flows together and access is so much easier for the patient, instead of us all working in silos like we are today. But you're right, Mickey, that is supposed to be, what we're supposed to be able to is pull up and drop someone off in a safe bed. But it unfortunately, according to the statistics, it hasn't been happening.
I was just here thinking, if you need a place for withdrawals and all this kind of stuff, would an old school work? Divide it up into like sections and have a place where it's run by doctors, volunteer, whatever, and then the people go in and get withdrawals and stuff like that. An old school that's not being used.
I think our hope in the community is that we keep the current services that we have, the current location that we have. We just, as the needs-based planning research shows, we just need to change the way we're doing things. And we need to get together and do it together as a cohesive group. You're right, that would be great. But we actually have the infrastructure in our city to do what needs to be done. It's the education piece about changing the way we're doing it and understanding that opiate use disorder is a whole other kettle of fish, and we need to treat it accordingly.
Thank you.
Councillor Curley?
Thank you, Worship. Thank you for the presentation, and I'm glad it's been done here where the people at home have a chance to view it, because it's pretty hard to go around and do the program or show everybody in community centers, which are not open. So I thank you for showing that here to us today. This kind of goes back to, I remember the mayor mentioning a number of times that we have to start working together. Everybody's sitting at the same table. I think we've started in that direction by having different agencies sitting around the same table, that we have to work together in order to make this, to make it work. I mean, from the homeless to the opioid crisis to everything that's happening out there. Safe sites, I have always believed in the safe site because I don't like what I see on the streets today. So the safe sites, at least it was organized. So you're saying we have the infrastructure here. At one point you had mentioned about there is funding available. I don't know if the funding is coming through provincial or you're looking at local tax dollars?
No, this is all provincially funded money.
Okay.
And, you know, as we know, the government is pouring a lot of money into addiction services. The problem is, John, that we can receive all the funding in the world, but it doesn't mean we do a good job with it.
Yep.
And we know that to any parts in our community. So I think the important thing is I don't want us to hang our hat on funding. We know that every year in our community, we get approximately $2.1 million for addiction services. What I'd like to do, instead of focusing on needing more money for systemic change, is we need to do a better job with what we have. And I feel like if we can be accountable and prove that we can do a better job with what we have, then we can make noticeable changes in our community. I fear if we worry and wait about more funding, then things won't get done. Because it's not that we have no funding. We could always use more funding. We can all, but I think we need to do a better job with what we have currently.
And I appreciate that. It's always nice to have extra funding. But where I was going with it is a lot of these agencies work Monday to Friday, 8 to 4, and then everything closes up. What happens after 4 o'clock or what happens on weekends? Everything happens after 4 and on weekends. So that's what I was trying to get at. Is more funding going to be needed for these agencies to provide more staff? Or is it all going to be related back to the hospital to cover the issues after 4 and on weekends? Again, everybody's got to sit down and make this thing happen. But the after hours, 24/7, as you explained in your presentation, that's what we need here. But was the dollars needed to make that happen? That was the question. Thanks.
So the way I look at it is, right now, I'm just going to give an example. I have if we pick any service, maybe we're servicing 1,500 people a year, what I would consider with not the best evidence-based practice. And there's very high relapse rates in our community and very, very high overdose rates. If we could take 500 patients with the same funding and service them very well, have reduced opiate deaths and reduced relapse rate, we're servicing less people, but we're doing a way better job. And they're now living the life they want. So 24 hours, 7 days a week, 365 days a year. Yes, I agree. It is going to take up more manpower, but we have to sit down and talk about this and look at this and see how it's going to look. Because if we're going to offer true addiction treatment in our community, that must be how it is. That's how it is in other communities. That's how it is in the South. You know, so we need to do that. But there is funding. So I agree that people worry about it. How are we going to open 365 days a week? We have to sort that out and figure that out. But there is a lot of provincial funding coming. And we know that. We see that in the paper all the time.
And this is a good start. At least I think the city's on board, and we have been on board. It's lasted a while, bringing everybody together. So it's a good start with you to make the presentation.
And we've received some more funding in the last couple of days, John. I don't know if you saw that in the paper. We received some extra money for some home mobile withdrawal management and also, for the Jubilee. But again, we can provide with this funding, but we need to ensure we do a good job with the funding we receive and don't do a disservice to our patients.
Yeah, for example, home withdrawal management services from the hospital, we're keeping stats. So for example, if she works 8 to 4 Monday to Friday, well, like you said, these issues happen at night, on weekends. So we're keeping stats on that to say, listen, you're working Tuesdays, we barely get calls. You're not going to work a Tuesday anymore. You're going to work a Saturday. So we have to be able to change how we do things by keeping data and when things are more, and you have to change. You have to be able to do that. That doesn't necessarily take more funding, just changing how you schedule.
This is going to be dynamic. It's always going to be changing. Healthcare is always changing. The emerge is dynamic. Everything we do every day is very dynamic, and we have to understand that this programming for these individuals, and drugs are changing constantly. The tainted drug market is changing. We must have to change. And if we keep stats, it makes us accountable. We need to prove that we're making a difference in patients' lives. We need to prove that people stop dying from what we're doing.
Councillor Murray?
Thank you, Your Worship. I actually work with Dr. Bellemare, so I'm pretty pumped that she's here today. Yeah, she hasn't shared a lot of this with me, so it's kind of a little bit of surprise. So this is her little baby that she's been working on and nurturing. But, much needed effort to have this done. So I congratulate both of you on this hard work that you're presenting today. We are losing a lot of people. Personally, I lost someone over the weekend. So it's tough, and it does impact us all. So I think the fact that you're really bringing this forward and the community gets to hear about this, right? Because we hear it a lot. We get emails a lot just about the crisis and sort of one side of it. But these are individuals who are struggling with addictions, right? So I think it's really important to understand that it's going to take a lot and we have to innovate. So I hear that is kind of like the common theme is we have the resources. We can do this in our community, but we have to innovate. We have to, get with the times. We can't be doing what we've always done because we're going to end up in a worse off situation. So really facing our current situation, gathering everyone up and moving forward together is really what we need to do. So thank you so much for the presentation. And I hope that, people are inspired, whether they be working in the field or not. But we need to be in front of this. And we need to do it together. Thank you.
Councillor Marks, and then Councillor Malone.
Thank you very much, and it's just wow in my head right now, like wow. I wrote down about the umbrella organization because I didn't get my head around that, but in your last explanation, it came together. And then I'm thinking about who would be the lead, how would people divide up resources, but that would be identified. Then, of course, the money question came up. Then I'm thinking Lynn, their responsibility potentially with this. And then the safe site location potentially. With all that, what can we do tonight or next week, this council?
I think the most important thing is there's a lot of stigma in our community.
Yeah.
And it is, right? People are entitled to opinions. But, we always hope when we present true evidence to people and back ourselves up in what we say, that the ignorance goes away and we can change people's minds. Because I think you can have an opinion, but you can't just be ignorant. And I'm hoping today the most important thing is we need to support this change. And my hope is that all these community partners that have been around for many years, who have been doing good things, it's just that in the last 5 years, the world has changed with respect to drug addiction, and we have to change. It goes back to what you said. We need to have one big group focusing on all these little parts so we can all move together to make it easy for the patient. I think the most important thing is moving forward is we do have meetings coming up, meeting with community partners to look at changes, positive changes, where we're going to go with this. And so I think we just need people to understand and support us. And I hope we can come back. And, this is my wish, is that we can come back in a couple of months and say, these are the amazing changes we've made. Statistically, we've had, we've saved this many lives. There's this many less. This is what we need to prove to our community.
Please use us as that vehicle and that voice. That's one of the things this table can do for you. Thank you.
Councillor Malone.
Thank you, Your Worship, and thank you very much for your presentation. I had the opportunity to join the call that the meeting that was hosted by the city and the Northeast Lynn that on which you had presented already, and during that meeting, my reaction was like Councillor Marx's, where I was just wow and blown away by the stats and by the evidence. And it wasn't any easier to sit through it again tonight. So I think, the urgency that you're both speaking with, and thank you for the passion that you bring to this, because I think it's very important. That sense of urgency, I think, is being felt here tonight. And I don't know what the viewership is like for these meetings, but I really hope that, of all nights, people are watching this meeting because it is an important topic. I believe you already answered some of the questions, so I'm not going to kind of, I wanted to get a good sense of where we were at with this umbrella model, and I don't know if it's too soon to be asking, but where are we at with that?
It's too soon, right?
Okay.
These are our dreams. These are our dreams. This is what we think would be best for the patient. We're picturing the perfect world for the patient right now. So we're meeting with community partners. We're going forward with these discussions. I think one of the most important things is getting it out there in the community. We need people to understand the evidence that's out there. And I think if we can do that, we can make really good changes. So it's too early to talk about that, but we're just really hoping that's where it ends up.
Yeah, and I just hope whoever takes on the role as the umbrella model, I just hope the other organizations agree with this, because I think that needs to be done. Mm-hmm. So it's hard because it's a big change for some of these organizations. They've been doing certain things a certain way. So we're just kind of letting them kind of, think about it. And now we're having meetings and moving forward. We've had a lot of meetings. This is a full-time job, I think, that we've taken on. But I just hope people come around and are open to change and agreeable that it is about the patient and saving lives.
Thank you. And if I may, Your Worship, I couldn't agree more. We need to be working in synergy and, find those efficiencies. If we're spending money on the same services, we're getting all this funding, and the French expression is on travaille des doublons. We're working on a lot of the same things. We just have to start doing it a lot smarter. My question was like Councillor Marks, what can we be doing as a councillor? I heard you. It's essentially support the work that the experts in the field are going to be doing on this. And I just wanted to mention that I was really pleased to see that the title of this delegation was Medical Perspectives, because one of the voices that we hear often, and we're seeing in the emails that we're getting and the calls that we get, we often hear the voices of parents and grandparents that have lost loved ones to this. And one of the voices we don't often hear are those of the children that are being left behind. And it's getting personal because I have a friend who is just affected. But for those kids, they're not seeing their parent as an addict, they're seeing their parent as a sick person. And so this is very important that we start treating this as a medical issue. Thank you.
Thank you.
Totally agree. And I think there's so much stigma out there. People blame the drug issues on the shelter. It's all living spaces problem. I think we need to say it's our problem, and we need as a community to solve this and stop blaming others. We know what we have to do. We just have to do it.
Councillor Robin.
Thank you, Worship. A couple of times tonight, there's been a few comments, and I don't want to repeat the council members' comments or questions because they're appropriate, and we have a pretty good council here. But what's come up a few times, you mentioned it again, is the stigma. Now, I'm a smoker. I don't smoke now. I quit a couple of years ago. But that's a socially acceptable addiction. Alcoholism is another socially acceptable addiction. So when someone's addicted to heroin, they're shoved into the corner. They're shoved into the basement, and they're blamed. They're blamed for falling to their own addictions. Now, if I fell off the wagon, so to speak, and went outside and had a smoke, it would be instantly forgiven by everybody. No big deal, Corey. But that one smoke isn't going to kill me. Being away from heroin and going back to the same level you had before will. And that's where I think we need to focus on that public perception. You're not a demon if you're on heroin. You're not a demon if you're an addict. You just happen to be an addict of a non-socially acceptable addiction. And if we can keep messaging that and saying, like, these are the supports for you, please don't hide in your basement. Please don't hide. If you reach out for help, we need to find a way to get it before 6 weeks. So we can do this just by being positive in our messaging and saying, if you need help, there is help for you. There's help for every other addiction, and it's public, it's socially acceptable, easily acceptable. Why not this one?
And I agree. I think that's a part of why our overdose rates are so high is people get shamed into using alone. And that, it was excellent what you just said, and I really appreciate that, because that's exactly what we're trying to say to people, that people get shamed, that they feel shameful that they have an addiction and they hide it. And most people who overdose alone, and they're found by family members because they're shamed. And this is why, another reason why we're pushing for the overdose prevention sites or the safe consumption sites, because there's no shame. People have somewhere safe to go to use. And every point of contact that someone with an addiction has with medical staff, non-medical staff, or a counselor, again, plants another seed that maybe next time they'll consider abstaining.
Any other questions or observations? I'd like to say a couple of things. Number one, last week we had our first conference with the mayors for with North Bay and Sudbury and Sault Ste. Marie and Thunder Bay and Timmins, who support this call to action because we are in a crisis. 46 deaths per 100,000 in our area is probably the worst in Canada. Every single mayor in those communities realizes things have to change. And the holistic model that you presented is the solution, and it should be the solution with every community. We all received the letter from Dale Minor. The grandson died needlessly, waiting for 6 weeks, and he died, and he didn't need to die. As I said in my final paragraph there, if there's going to be any upside of this conversation, then it's one, we don't have the authority funding, but we have the moral authority to end the apathy in this community. This is what this council can do. This is what council is charged with. We can change, we have the moral authority to change the apathy regarding this crisis that we're facing. And it's our imperative to do this. And I know we've got the council's support of this. It was a brilliant presentation. It won't be the last we hear of this. It started with a call of action that CEO responded to, and we've had a brilliant presentation. I think when just the fact that we have these types of presentations here in this council, this presentation, it gives me hope that we can change things and things will get better. Thank you very much. That's a very, very dynamic presentation. Thank you very much. Can we perhaps take 5 minutes just to collect ourselves? This is very impactful. It's very difficult then to switch just to a financial update. So perhaps we can just take a break for 5 minutes. So Natalie happens to be, do we want to do Pat first?
I think that's what's next.
Kevin?
No.
Are you going to do it first?
Sure. Right.
Yeah, are you going to do the update? Or? Okay.